So that's the end of what I wanted to talk to you about, and I'm going to introduce to you Dr. David Flannery, whom most of you probably already know. Dr. Flannery is a professor of pediatrics at the Medical College of Georgia and a vice dean of some unit there, and I'm not sure exactly.
Vice chair.
Vice chair, that's the right one, sorry. But in any case,
yes.
Among other things. Thank you, David.
Well, thank you. I'm glad to be here. We were talking about our experience at now what's called Georgia Health Sciences University. Medical College of Georgia's name has been changed. We have a new president. The Board of Regents approved this change back in October. I believe it's October. And it emphasizes the fact that, like MUSC in Charleston, it's not just a medical school, it's got all these other schools to it as well. And let's go to the next slide. I have one disclosure here, which is that I'm an uncompensated member of the Board of Directors of the Georgia Partnership for Telehealth, which is a not-for-profit entity that actually runs the Georgia Telehealth Network. The other disclosure I just realized when I was sitting back talking to Paul Fernhoff is that I'm also on the Board of Directors of the MCG Health System. And the MCG Health System oversees MCG Health Incorporated. And MCG Health Incorporated is an investor and part owner of ReachCall telestroke systems. So I'm like doubly conflicted here. Those are my disclosures. We'll start back here. Georgia, you all know, is the largest state in land area east of the Mississippi, and yet, you know, we have specialists concentrated in very few areas, like Atlanta, Augusta, Macon, etc. And so getting access to care for Georgians has always been a challenge. Next slide. Back in the the early 90s, the GSAM system was set up, which was the Georgia Statewide Academic and Medical System. It was headquartered in MCG, and it was a hub and spoke type arrangement for telemedicine. Next slide. And so in 1995, we decided to get into telemedicine since we had it. And so we offered acute or urgent consults using this network, and we let folks know about it. Actually, the first telemedicine consult I did was on July 4th of that year to Albany, Georgia, and it was to an NICU there. And it was a baby who had Pfeiffer syndrome. And they actually moved the baby from the NICU because it was stable to where the telemedicine setup was. Really, the acute model was not very successful. Very few people would ever call to set up the urgent or acute consult. So we decided to start a new model, which is to have regularly scheduled outreach clinics that are virtual clinics. And we just said, here we're going to have this. Children's Medical Services at Waycross, Georgia, at that time, and for years in either direction of that year, had a very visionary health director. And he thought this was a fabulous idea, so we went ahead and set this up. We had already done in-person outreach clinics to Waycross every other month, so this was supplemental to those outreach clinics. Next slide. And so what happened is we were doing that, just going along with Waycross as our primary site for doing telemedicine clinics on a regular basis. And GSAM started having problems because there were high startup costs for facilities. They had to pay somewhere around $100,000 to outfit a telemedicine room. That's the state of the equipment at that time. And they had about a $2,600 a month line fee because they had to put in a T1 line of their own and pay for this. And so distant sites started dropping out towards the end of the 90s. And so next slide. Waycross said, well, we really like this telemedicine stuff. We're going to figure out how to maintain this. And so a nurse who worked there, and they found a guy in the community who was techno-savvy, and they created their own dedicated telemedicine system between one of their clinics in Waycross, Georgia, to MCG. It's internet-based. And this talks about one of the things I mentioned. Sustainability, depends on commitment. You got to have people who partner with you and want to make this work. We're still using this internet-based point-to-point system. We have a cart that is housed in our office building, And we roll it out to my office for my monthly Waycross telemedicine clinic, unplug it from the internet, store it, roll it down the hall for the allergist to do his clinic when he has that as well. Next slide. Then there was a creation of a new statewide telemedicine program in 2005, and this is related to the Anthem and WellPoint merger. And the insurance commissioner at that time came up with this idea to have a rural health initiative that included a statewide telemedicine program that included WellPoint investing $11.5 million over a 3-year period of time to set up a telemedicine system. Next slide. And so we now have in Georgia this telehealth system, and you can click it again so this thing has come up. So we have different specialty centers, we have just, whoops, sorry. And so this is an open access network because, you know, let's say this is a specialty site, so that's where I am, being the consultant. You know, I can connect to any place else on the network. But a distant site, let's say this was Valdosta, they could be an originating site, have a consultant there who would then be doing outreach to other places on the network. Another advantage of this is that I can be in Augusta, and I can go to Valdosta, to Douglas, to Tifton, to McRae, and back around just by flipping a switch. Next slide. And so then, as the 3-year mark was approaching, it was said, like, well, what are we to do now? So they created a not-for-profit entity called Georgia Partnership for Telehealth. It was incorporated in December 2007, and it's been very successful at developing and maintaining the telehealth network in Georgia. Next slide. This is their homepage, and basically they exist to develop the network and maintain it and provide services. And so when we have a clinic, the doctor at a distant site can call GPT people, set up the appointment, put it into our calendar. It's an online calendar that my secretary can access or our schedulers can access. We can port the information from there into our scheduling system, which is also our billing system. So they do a lot of this for us. They do the credentialing. Now, Hans mentioned credentialing. Up till now, you did have to get credentialed at every site that was a J-code site. So if it was a hospital or a hospital-affiliated site, you had to be credentialed at that site. GPT helped with the credentialing process. They would maintain your standard application and send it out to any site that you needed to be credentialed at. Just the other day, I found out that there's going to be a new regulation or policy which is going to allow distant sites to essentially deem your credentialing. So if you're credentialed like I am at the Georgia Health Sciences Medical Center, which is what we became yesterday, if I'm credentialed to telemedicine there, hospital, Archbold Hospital in Thomasville could go ahead and accept that as being credentialed at their place, which is going to make things a lot more efficient and save a lot of trees. Okay, next slide. And so we've got the 800 number, staffing to support the program, they do the scheduling, they've got telemedicine liaisons who go out there. I did a telemedicine clinic to a site, I can't remember the last time, and they had never really done this before, so they actually had a field liaison actually there, you know, holding their hand, going through the whole process to make sure it gets done properly. And they also worked on things about getting reimbursement, dealing with all these other issues that are something we'll talk about in a second. Next. Here's a picture of all the sites in Georgia right now on the GPT network. Next slide. So currently, there are 224 presentation sites. There are hospitals, clinics, nursing homes, physician offices, schools, jails, all kinds of sites. There are 21 specialty or specialty sites, so those are consultant sites that are designated. So that somebody wants to make a referral can call GPT and say, hey, you got a pediatric dermatologist. They, well, yes, we do, in Thomasville. So that's a specialty site for that. There's currently 184 specialists that are enrolled on the system, representing 40 specialties, and you can see the list of specialties there, and includes genetics. It started being utilized in 2005. In 2010, there were up to 31,000 encounters on the network, and it's increasing steadily. They've also got funding just this year. They're the Southeastern Telehealth Resource Center. And it's for Florida, Alabama, South Carolina, and I forget what the other state is there. But I think they would consult with just about anybody. They've had international people coming just this past month visiting them to learn about this. I think it was Nigeria came to visit them. Here's the equipment. It really is just high-tech video conferencing. It's nothing more complex anymore. This is a Tandberg unit. I think it's called a Scotty. It has really great high resolution. It's really good. I like that. That's not a plug. There's another cart there like we use for the Waycross telemedicine. They roll it from site to site. Next slide. And so we can see and talk with the patient and family at the distant site. You have an interview camera in the telemedicine room in these sites, as well as an examination camera. Next slide. And here's Dr. Deborah Lister, who is at an ambulatory clinic affiliated with Coffee Regional Hospital in Douglas, Georgia. And they're a high volume user of telemedicine to get specialty consultation for their patients they see there. And here she is in Douglas, and there's somebody, I don't know where, and there's a picture of the person's ear down there. I have a better picture for the next slide. And here's a consultant, at the distant site, seeing the encounter, talking to the patient, can capture images to use them later. Next slide. We also have different scopes that are attached. They're all digital. Next slide will show we're using a dermoscope. Has a fixed weight there, so you get a good sharp image. And you got the picture of the skin up there, so a dermatologist can go to town on this system. Next slide. There's the eardrums with otoscope. We also have ophthalmoscopes. And just to look at the back of somebody's throat, we just take the head off of the otoscope and just use the camera and sort of look at it. We also have a wireless electronic stethoscope. Next. We'll skip this because I want to be respectful of people's time, and I can show you a video clip at some time. So currently, what am I doing with telegenetics? Using the GPT network, I've expanded now to 2 half-day sessions per month. I was doing 1, the demand was there, expanded to 2. The Waycross telemedicine hookup, which is separate, we're doing that 1 half-day a month. Next slide. So in the GPT network clinics, we are averaging 5 patients per session. The no-show rate is 0 to 33%. Very often, it's 100% show rate. We have multiple distance sites. I mentioned this earlier. So I sit there, and I just say, where's the next patient on the schedule? Oh, so the 10 o'clock patient is at Valdosta. So we bring up that IP address, click it, and bang, we're there. Can go around the state.
David, what does GPT stand for?
Georgia Partnership for Telehealth.
Thank you.
Now, most of the patients we're seeing on the GPT network have developmental delay plus something else. Dysmorphic features, growth problems, or family history of something. 75% of them are new patients. Next slide. The Waycross Telemedicine Clinic is a more mature clinic. We typically have 4 to 6 patients scheduled. We have a 25 to 50% no-show rate. Many of the patients, almost all of them, are follow-up patients. This is an example of my clinic 2 weeks ago. So we had a child who has Down syndrome plus fetal alcohol syndrome, mature mother who drank, tuberous sclerosis, Beckwith-Wiedemann patient, and a patient with an unknown dysmorphic syndrome who we just keep seeing and saying, well, maybe the chips will get stronger and we'll redo this. Everybody wants to know about finances. So, for this fiscal year, which started July 1st, I had our practice group people pull all of my financial activity that were closed balances. In other words, they've gone through the whole process. The bill's been submitted, it went to the payer paid or didn't, it may have been a denial, it finally got settled. So for this fiscal year, so that's through May, we have, I'm not going to show you the dollars because that's proprietary, but our net collection rate is 100%. Are you familiar with the concept of net collection rate? Because like no payer pays you what you charge. You have a contract and they pay you a certain amount and you agree to take that or not. Well, if you don't get all of what you're entitled to, then there can be problems in your billing process, how you code things, how you do a variety of things. You may have a patient's name misspelled, who knows. 100% net collection rate, which is excellent. It means the folks in the distant sites are getting all the correct information for us, all the insurance information, and then we're doing our billing properly. We have no bad debt. Bad debt would be what led to the net collection rate being suboptimal. You want to know finances? My collections have been $125.34 per encounter for this fiscal year on telemedicine. And that's between the two systems, the Waycross one as well as the GPT. And net collection rate is 100% for both of them. So it's working well. I tried to get data about the distant sites to see, because they can have charges as well. They can bill and collect. The Waycross site is a children's medical services site, and it's not billing for that. There are too many distant little sites in the GPT network for me to get meaningful information. Douglas, Georgia is one of the bigger users that we've had. They have a relationship with me on the GPT network. And they are charging a facility fee, and they're charging a fee because there's a physician present handling the encounter. They don't know what they're collecting, but they do know that they are submitting charges. And there are proper codes for that they should be able to get paid. Next slide. So, more than a decade of doing this, what have I learned? Well, genetics can be done by telemedicine. The quality of the interaction with patients and families is very good. The image quality is good for dysmorphology. This is now really getting to be very high-def stuff. Patients are satisfied. We formally assessed this several years ago with actually a survey. And it showed that they had very high satisfaction. Now you notice that the show rates vary. Our counselor and I feel that this is correlated with the enthusiasm of the person at the distant site who's signing the people up for telemedicine. If they're a real enthusiastic person saying, isn't this cool, this is like Star Trek, the people get more jazzed up about it than if somebody says, well, you can see Dr. Flannery in 2 months in person, or you can see him next week on telemedicine. It's sort of like, that's not selling it, is it? So we've discovered that, it's varied from time to time, and so it's clearly how well you prepare patients and how you sell this. Next. Other lessons. Most patients and families really do well with telemedicine, but there are some people who do not. And it can be really painful. And it can be a variety of things. One time we had this mother who did not realize, what she looked like. Sort of a disheveled person who had some gaps in her teeth and stuff like this. And she just froze because you can see your image, when you're there. And it was like, oh God, please, let's be kind to this person. It's like you need to sort of out of the room. Another time though, we've had ask the mother questions, she keeps turning to the kid, like the kid's supposed to answer the questions. It's like, so it would be helpful if the coordinator at the other end has a sense about the patient, especially the referring physician, to think about how this might go. I mean, if it's a person who's not particularly talkative, it can be very painful in telemedicine. Next slide. Now, conducting a telemedicine genetic encounter is different than seeing a patient in person. You have to pay attention to your clothing. You know, I'm wearing a typical shirt I would use to do telemedicine. One time, I just wasn't thinking. I had on a royal blue gingham shirt, and I had this patterned tie, bow tie with it. And like I walked into the building and went, oh God, I'm going to telemedicine. I cannot imagine what this looks like if I move, because sometimes you get occasional pixelation and stuff. And I'm like, never again. So you want, solid colors are good, nothing too bright. You don't want white, because depending on the lighting, it can wash you out, and you don't look very personable then. And that gets to the thing about interacting on camera. This is media. You are acting, and so you reach out through the screen to people. You got to be a little more interactive with people than you would be sitting in a room 3 feet from them. And it's just part of the fact that you're on television. And you need to maintain eye contact. At one point, we had one system, and the camera that was on me was over here. And the screen here where the people are is here. And you kind of look in there, and it's like, gosh, you've got to move this camera front and center right above so you can maintain eye contact. Now, the way we do the session is we have chairs set up, the interview camera. We introduce everybody. We explain why they're there, just like any other session. Interview the family, get the history. And then we say, okay, now we're going to examine the child. Now, small children, just like you do in person, you could do it in the mom's lap. And just get the exam camera to zoom in and get on the child. Otherwise, you put the child on an examination table. And the nurse or assistant is there with this, assisting in moving the child, getting in position, holding the stethoscope, holding the otoscope, etc. And we use the exam camera. And we can control the exam camera remotely. Then we go back to interview chairs to talk about, just like you would do in a regular session. And then I give instructions to the nurse, the assistant at the remote end. I may fax an order, for lab tests, things of that sort. And then it's important to realize, close the session. Say, well, thank you for coming in. I hope this was very useful to you, and here's what's going to happen. And we're done for today. Because it still happens in a regular clinic. If you don't remember to reach closure of the patient, you walk out the door and the patient's still sitting in there, not realizing it's time for them to go. Next slide. So then, we talk about what else can you do with telemedicine? We've done some follow-up of patients with inborn errors. It's video conferencing, gosh. The physician component is reimbursable. We would have to get a waiver for the dietitians to be billing for services on telemedicine. Commissioner Oxendine is no longer insurance commissioner because he stepped down to run for governor unsuccessfully. So we don't have as much of an advocate for doing things with telemedicine, but that's something we could visit. Next slide. Genetic counseling by telemedicine. This would be great. In cancer genetics, people already have diagnosed Mendelian disorders, CF, etc., or multifactorial disorders. Next slide. Anyway, there are other opportunities. You can do store and forward consultations with telemedicine. It's basically secure email. You can send images. It'd be great for dysmorphology. It could easily go across state boundaries, except the licensure issues. It's informally already occurring. I don't know, Paul, are you on the skeletal dysplasia listserv, or Hans, are you on that?
No.
Because people will post x-rays on patients and history patients. And every geneticist has expertise with a particular syndrome, gets calls, emails, about their syndrome, and people send them pictures and that kind of stuff. So, we need to make sure that it gets formally structured to be the definition of the practice of medicine that would be recognized by state medical boards. But that's something that I think, certainly could be done. Next slide. Now, barriers, we talked about credentialing issues within a state. It has to do with J-code, as I mentioned, that's changing. Hopefully, it will be implemented this year. So that once you get credentialed at one place, other folks can just accept that. One problem that I've had, which is interesting, is I was credentialed at 38 sites. And I didn't have enough activity for my quality to be assessed to maintain the credential at a distant site. Well, no joke, I saw no patient, you know. And so that's kind of difficult. So having this deemed credentialing will get around that, because in aggregate, obviously I'm doing a lot of telemedicine, so I am maintaining the quality in my competency. Next slide. Some states may not include telemedicine as a recognized form of the practice of medicine. It's really interesting. We've been doing telemedicine in Georgia for since '94 probably, in general. And the Georgia Partnership, was part of their activities when they were starting up, they discovered that the state medical board in Georgia actually had not included a definition of telemedicine as a medical service, and potentially physicians who were providing telemedicine care were engaging in unprofessional conduct that could actually be, censured by the state licensing board. They got that fixed quickly, unfortunately. But many states have not resolved these kind of issues, and that's something that the Southeast Regional Telehealth Resource Center could be helpful in helping with that. Only 11 states in the country have enacted legislation that requires reimbursement for physician telemedicine services. Georgia obviously does, but insurance companies in many places you choose just to ignore it. Next slide. There's low or no reimbursement to the originating site. It's not unique to genetics, it's telemedicine in general. At a national level, the American Telehealth Association is addressing those kind of policy issues. And this becomes an issue, like Hans was talking about, for the distant site in Louisiana, or wherever it was. They make this investment, they have ongoing costs, and you're not having very much use of it. They're not getting any offset to their expenses. So that's a challenge. Next slide. And this is just reiterating about coverage, because telemedicine needs to be a covered service by the insurance company, not just the fact that reimbursement's got to be covered. Next slide. And the complex logistics that Hans mentioned, if you want to do an acute consult, you got to call this person, find out they're available, then find out the patient can be available, get all these people together. And you can see why having at least a set clinic that has slots that people can schedule into. I don't have to say a word about it. They just get scheduled in there. And I just show up and do telemedicine. But there's still, the Georgia Partnership for Telehealth, they charge each site $256 a month for the access to all these services, as well as helping with maintaining the connectivity. It's not too expensive when you think about all the service you're getting. All right. And then sustainability challenge, Hans mentioned, you've got to have some kind of way to offset the cost. I mean, the subsidy, is certainly one of them. There might be opportunities, let's say a managed care Medicaid provider decided that they wanted to encourage the use of telemedicine for their patient population on their covered lives. They may find it reasonable to contract with somebody to do like after hours, pediatric care. Say we've got 40,000 covered lives, and we're going to pay you 33 cents a month, to handle this. I mean, people are doing that kind of thing now around the nation. The lowest cost yet clinically effective equipment to provide the service is the key. And what Hans is alluding to, is why do you have to have this super complex, thing? We can actually now do telemedicine using laptops in what's called the MOVI client on a wireless network. You can't do this on an iPad or your iPhone because it's not HIPAA compliant. So don't jump into that just yet. But with the Movi client and the wireless network, it can be compliant and can be done. That's something we want to do. Our telestroke people, the chairman of neurology talks about how he was on stroke call for telestroke, and he got called and he pulled up his laptop, was using a wireless hotspot of Taco Bell. So it can be done. Next slide. Key ingredients of program success, I mentioned to this. You have to be committed to doing this. You have to have a desire to do this. The administration and staff have to support it. You need a champion for telemedicine. So Douglas, Georgia, Dr. Worcester is the champion for telemedicine. And she's made sure that they use it as much as they can. You need space, you need a budget, and you need to have network connectivity, IT support. You got to know what to expect. You have to have program planning. Pay attention to billing. If there's an opportunity to bill, make sure you're doing it right. Next slide. It's worth the effort. It improves access. It connects patients and families to genetic services they couldn't get otherwise. We already do outreach in person to many sites, but this makes it even easier because I go to Waycross now, more often, virtually as well as in person. The cost of care is decreased. This is one thing that potentially could be sold to people, like to a managed care network, and is that it's going to cost less. And it saves us travel time. The drive from Augusta to Waycross is down US 1, and I actually showed pictures of it when I talked about telemedicine a number of years ago. And it looks like the same pine trees because you're driving down US 1. It's like just boring. It's 4 hours. Doing it just like that is excellent. It's more productive, and you enhance your revenue, and you avoid lost opportunity encounters at your home institution, because if you're not here and you're somewhere else and somebody gets this wild idea to get a consult on a child in the child psychiatry service, well, they may discharge them tomorrow, you don't get a chance to see that kid. So you can actually be in 2 places at the same time, if you think about it. Next slide. Well, I mentioned they're back up there. Green, it's a green service, because you're not burning all this fuel traveling around too as well. So if you're interested in telemedicine, especially the folks who are outside on this presentation, you can contact me. Here's my email address. You can check this site here to determine if telemedicine is available in your state. Different parts of state entities do things that everybody else doesn't know about. So you can find out there. And if you need help with developing telemedicine, you can consult with the Southeastern Telehealth Resource Center. And that's their web address, and that's their mission. They're funded to help get this done. So with that, thank you for letting me come and speak, and I'm happy to answer any questions or comments that you all have.
Thank you, David. I kind of wanted to add a couple of comments to this, because as a part of our regional collaborative, we've been looking, and I know some of us, including Trish and all, met with the Georgia telehealth people to explore, and I know genetic counseling is considering starting a clinic, or we're exploring.
Well, we're certainly exploring that. One thing that you mentioned though is that reimbursement is not.
Well, because we looked into it, and counselors are not billable entities, and so you end up doing the same thing you do now, which is like have a physician that hailing distance while you do it, so you technically can bill that way. Well, that sort of defeats the whole concept of using your resources more efficiently. One thing we thought about was that we get a fair number of patients sent to us by TRICARE from Hinesville, who come all the way to see us for basically a genetic counseling visit for cancer genetics. They do newborn screening with pediatrics with an X, and so they're sending us kids with G6PD deficiency to counsel them.
Right.
And it was like, God, it's a no-brainer. Well, there's no telemedicine facility in Hinesville. But if there were, we said, well, I wonder if the Army, the military, can recognize a counselor as a billable entity, because that's a federal thing, that's not a state thing.
Right.
We haven't explored that because, as you can imagine, tons of other things to look into. You know, the real challenge is that counselors are not licensed. And then you have the whole challenge, you know, when you have a limited number of counselors in a state, of how you get the political clout to get licensure set up. You know, that's the challenge. At least we have more counselors in Georgia than they have. There was one state up in New England, I think it was Maine or Vermont. They wanted to, you know, get licensure, and there were like 5 counselors. They said, well, who's going to be on the licensing board? You know, passing judgment and assessing these people, like, you know, it's just like, you know, just too small a number at the expense of setting it up. The state said it's, you know, not something to do. But addressing the question of national licensure for telemedicine across, you know, state borders, you know, Hans and I were at a policy development conference in November of 2009.
Yeah.
You know, the white paper is coming out sometime.
Soon.
You know, it's encouraging that kind of practice to brief access.
So anyway, the impression from Grantman's perspective, what we get is it's a high priority nationally in terms of the vision, but the actual effort, everybody's stuck at various places and how to move with the current healthcare environment. But I do think the only way we are going to be successful is by partnering. So the Georgia Telehealth, they've gone outside Georgia now, and they have in our southeast region, and also talking to our state people. It's a big state priority in talking with our local state people at the health department level, Title V people and all. So they have limited resources, so we'll probably have to start a combination of non-billing. 35% billing may go to 40% or 50%, but that's the avenue. We plan to maintain this in our next grant cycle. Hope to continue collaborations and learn from David, and of course Hans is going to remain active, and we'll keep you posted. So thank you so much for coming today.